Good afternoon to all of you. On the offset, I would like to thank the organizing secretary, the chairman, and the members of the scientific committee for giving me this opportunity to speak on indications of mediastinoscopy in the era of EBUS. Sorry. Lung cancer has been a major health problem. It's approximately 1.6 million tumor-related deaths occur annually worldwide. A very small proportion of patients are diagnosed at an early stage of the disease, other present with no distant metastasis. Most of these patients with lung cancer will have an indication of an invasive staging of the mediastinum. Mediastinoscopy is a surgical technique that permits minimal invasive access to the mediastinum. It is used mostly for biopsy to facilitate the histological diagnosis of enlarged mediastinal lymph nodes, carcinoma, sarcoidosis, and tuberculosis, and masses as lymph nodes, germ cell tumors, and thymomas. Mediastinoscopy currently plays a particularly important role in defining the clinical stage of bronchogenic carcinoma. Staging is the first step towards determining the optimal course of management. Staging directs treatment, implementation of protocols, and permits comparison of treatment between patients. Cervical mediastinoscopy was first described by Harkin in 1959, which involves a neck incision that facilitates access into the superior mediastinum. Garland and Pearson popularized the technique using a special design mediastinoscope through a suprasternal incision. Cervical mediastinoscopy, however, has a limited access to the aorticopulmonary window or the AP window. There are different types of mediastinoscopy which have been invoked. Extended cervical mediastinoscopy. Mediastinoscope is inserted anterior to the aortic arch between the innominate artery and the left carotid artery, and this procedure is rarely used now. Anterior mediastinotomy, so-called mediastinoscopy, which is one of the most common approach to AP window. Subxiphoid mediastinoscopy is a technique in which the mediastinoscope is used to biopsy anterior masses in the lower mediastinum. And last but not the least has been the video-assisted mediastinoscopy, which has better sensitivity and is more comfortable for the surgeons to be used. These are the instruments and the biopsy forceps. And you see the mediastinoscope there, and in the picture you see the mediastinoscope, how it is inserted in between anterior to the aorta and in between the innominate artery and the left carotid artery. These are the various stations which need to be studied and biopsied, and ultimately which leads to staging of the patients with non-small cell lung cancer. Extended anterior mediastinoscopy is a technique used to sample mediastinum lymph nodes in the AP window. In addition, anterior mediastinoscopy can be used in a variety of peristernal locations to facilitate the biopsy of anterior mediastinal masses to the right or left of the midline. Subxiphoid mediastinoscopy is to biopsy anterior masses in the lower mediastinum. Patients who have been diagnosed with bronchogenic carcinoma are staged using a combination of modalities. Computed tomography of the chest determines the size and location of the primary tumor in conjunction with any associated lung parenchymal abnormalities, which may be atelectasis, collapse, pneumonia, emphysema, or fibrosis. In addition, the location and the size of enlarged mediastinal node directs further investigation to stage patients. Mediastinal nodes which are larger than 1 centimeter in the short axis are considered to be suspicious of tumor. The differential diagnosis of patients with persistent and unexplained adenopathy includes sarcoidosis and lymphoma. These two conditions are difficult to distinguish clinically, and histological confirmation is required. Sarcoidosis characterized by non-caseating granulomas that can readily be distinguished from both Hodgkin's as well as non-Hodgkin's lymphoma. In between conventional mediastinoscopy and video-assisted mediastinoscopy, there has been a tendency of higher diagnostic sensitivity with VAM, that is 83%, as compared to traditional mediastinoscopy, where the sensitivity is 63.6%. Potential advantage of VAM over traditional mediastinoscopy include enhanced views on the monitor and a more comfortable surgical working environment. The total number of dissected nodes have been found to be more with video-assisted mediastinoscopy group than with the traditional mediastinoscopy group, as various studies have shown. There are relative contraindications to mediastinoscopy, which include severe vena cava syndrome, severe tracheal deviation, thoracic aortic aneurysm, and absolute contraindications have been written: laryngeal nerve involvement, cardiac status precluding anesthesia, previous mediastinoscopy. Cervical mediastinoscopy, which is quite common, it can be done with low morbidity and mortality, but has its potential catastrophic complication. So because of this risk, surgeon must be properly trained in mediastinoscopy. The procedure is usually performed as a day surgery procedure, although it should be performed in a hospital setting because of the potential complications. The procedure of mediastinoscopy involves a comprehensive examination of the mediastinum informed by the CT scan findings. Sampling of the lymph nodes is directed by manual palpation and visual inspection. The common complications associated with mediastinoscopy are hemorrhage, pneumothorax, recurrent laryngeal nerve injury, arterial compression, tracheal compression, dysarrhythmias, whereas the unusual complications have been infection, tumor implantation, phrenic nerve injury, spatial injury, air embolism, chylothorax, and stroke. With the emergence of endobronchial ultrasound, a minimally invasive procedure probably providing valuable information for primary tumor diagnosis and mediastinal staging. Endobronchial ultrasound, when combined with transbronchial needle aspiration, is the less invasive procedure and is the first line of choice for patients with non-small cell lung cancer. The EBUS involves the convex probe. Radial probes are also available, and it also has a 22 gauge needle. The procedure is normally done under local anesthesia through nebulization with lidocaine and conscious sedation using midazolam. Each visible station is sampled systematically. The station which are having multiple lymph nodes on EBUS. The lymph node is biopsied based on the size on 18 FDG uptake. Cord tissue is placed on the filter paper to absorb the excess of blood and fixed in 10% of formalin. The tissue coagulum clot is sent for histological examination. Aspirates are discharged onto slides, smeared, fixed in 95% ethanol, and sent for cytological examination. The procedure of EBUS is done in 3 steps. First is localization of the lymph node, second is measurement, and third is the puncture. Usually 2 or 3 passes are conducted per node to obtain the core tissue. It is ideal for all interventions to be conducted by 2 bronchoscopists, but the practice varies from institute to institute. It is mandatory to map the lymph nodes and staging be done. Sang Hughes, in his prospective trial, has compared the diagnostic performance of the endobronchial ultrasound-guided transbronchial needle aspiration with that of mediastinoscopy in patients with non-small cell lung cancer. Patients with histological proven non-small cell carcinoma and suspicion of N1, N2, N3 metastasis were the ones which were enrolled for the study. Each patient underwent EBUS TBNA followed by mediastinoscopy. He had 138 patients who underwent EBUS and TBNA, out of which 127 patients underwent EBUS TBNA along with mediastinoscopy. The N2, N3 disease was confirmed in 59.1% of the patients, and there was significant difference in the sensitivity, accuracy, and negative predictive value were evident between EBUS TBNA and mediastinoscopy, and p-value was less than 0.05. EBUS TBNA has been superior mediastinoscopy in terms of its diagnostic performance for mediastinal staging of N1 to 3 NSCLC. Because EBUS TBNA is both less invasive and affords superior diagnostic sensitivity, is the first line procedure performed in patients with non-small cell lung cancer. Accurate mediastinal staging is vital for the management of non-small cell lung cancer. The optimal approach to invasive mediastinal staging remains controversial. Recent American College of Chest Physicians and European Society of Thoracic Surgeons guidelines have recommended a needle-based technique such as endoscopic ultrasound fine needle aspiration or EBUS TBNA over mediastinoscopy as an optimal first test. This recommendation was based on the systemic review and meta-analysis of the diagnostic performance of EBUS, TBNA, and mediastinoscopy. The pooled diagnostic sensitivity of EBUS TBNA ranged from 88 to 93%, and that of traditional mediastinoscopy was 78%, whereas that of video-assisted mediastinoscopy it was 89%, almost matching with the EBUS TBNA. A staging strategy combining endosonography and EBUS with TBNA and surgery compared with surgery alone afford higher sensitivity in detecting mediastinal nodal metastasis, and hence there were less futile thoracotomies. Now, comparison between the mediastinoscopy and the EBUS TBNA. Mediastinoscopy can access lymph nodes in station 1, 2R, 2L, 4R, 4L, and with difficulty and superior aspect of 7. The advantage is that it affords large amount of tissue for the genetic and proteomic analysis, better for diagnosis of some condition, for example, non-Hodgkin's lymphoma and sarcoidosis, faster than EBUS, checks multiple N2 stations faster and quicker, uses pathology and not just cytology, helps to dissect the out vessels for subsequent lobectomy, lower false negative rate than EBUS, whereas EBUS TBNA can biopsy 2R, 2L, 3P, 4R, 4L, and 7 stations. No incision needed. Can be done through IV sedation. Very low morbidity. Can be repeated in patients before and after chemotherapy and radiotherapy. Can be done after mediastinoscopy and can be done in patients with tracheostomy. Excellent initial results for N2, and patients who are 2L for mediastinoscopy are also and need to undergo radiotherapy for lung cancer for staging, are the other category where EBUS TBNA can be performed. The disadvantage with mediastinoscopy has been cost has been more, requires general anesthesia, it is difficult to repeat, risk of serious bleeding, and difficult to teach standard mediastinoscopy rather than video-assisted mediastinoscopy, which is more easier to teach. EBUS TBNA has disadvantage, usually only provides cytological analysis. Often ROSE is not available for all hospitals at all times, provides only small quantities of tissue, higher false negative rate, and higher user dependence. In an era of increasing cost pressures, restructuring of the healthcare delivery and payment, and heightened consumer demand, technology can be managed in ways that improve patient access and health outcomes while continuing to encourage useful innovation. Steinhorser, in his study, who had done a review of about 8 studies, and he suggested that EBUS is cost-effective compared to mediastinoscopy for mediastinal staging of lung cancer. To summarize, the benefit of EBUS TBNA are difficult to be defined. The benefit of EBUS TBNA over mediastinoscopies are marginal. Endobronchial ultrasound does prevent the very rare severe complication of mediastinoscopy. EBUS TBNA is substantially less invasive than mediastinoscopy, particularly when it is performed under general anesthesia, and mediastinoscopy needs to be performed by experienced surgeons. The cost of EBUS TBNA versus mediastinoscopy is less expensive with mediastinoscopy, especially when performed in the same setting as the lung cancer. Endobronchial ultrasound has a higher false negative rate than mediastinoscopy, and in particular, it has an unexpectedly high false negative rate in patients with non-enlarged and or non-fluorodeoxyglucose evade lymph nodes. To conclude, although near-diagnostic modalities are being increasingly used to diagnose mediastinal disease, mediastinoscopy continues to be a reliable method for investigation of mediastinal lesion. The mortality rate has been reported to be in the range of 0% to 0.1%. EBUS cannot image or sample subaortic and paraesophageal lymph nodes. Its availability is institution-based specific, and expertise is required to interpret images and obtain diagnostic samples. The inherent disadvantages of EBUS TBNA include lesser sampling of core tissue and an inferior negative predictive value. Only cytological studies are possible with the sampling of EBUS. Teaching mediastinoscopy has been difficult in the past with the conventional technique, but it has changed with the invention of the video mediastinoscopy. Exposure of anatomical landmarks such as pulmonary artery, the vena aequus and vena cava, the left recurrent laryngeal nerve, and the subcranial lymph nodes is further facilitated by visualization on the video screen. This helps in teaching and training of the surgeons owing to improved visualization and easier dissection. EBUS TBNA has a longer learning curve. Mediastinoscopy continues to have an important role in the sampling of masses and lymph nodes in mediastinum by providing a secure diagnosis to the patients with no lung cancer. Previous study, however, reported mediastinoscopy to be more invasive and linked to greater morbidity than TBNA. The prevalence of major procedures-related bleeding was reported to be in the range of 0.1 to 0.4%. In contrast, EBUS TBNA mediastinoscopy is a safe procedure with acceptable morbidity. In addition, lymph node sampling by mediastinoscopy has remained the gold standard approach for differential diagnosis of mediastinal adenopathy. The rate of morbidity is 1.3%. Various complications are known with the procedure, but permanent postoperative recurrent loud paralysis can be prevented by avoidance of electrocautery or local anesthesia usage. Mediastinoscopy is the most traditional method to evaluate mediastinal lesions. Still, it's the current option to evaluate mediastinal lymph node lesion. In addition to allowing sampling of the paratracheal subcarinal lymph nodes, direct biopsy of mediastinal tumors is possible with cervical mediastinoscopy. So, despite the recent changes in the guidelines and a shift to the minimally invasive endosonography for staging, acquisition of this technology in many thoracic surgery and pulmonology centers is hindered by the lack of EBUS TBNA expertise and limited resources. Hence, mediastinoscopy is still the test of first choice in many thoracic surgery programs worldwide for mediastinal staging, restaging, and diagnosis of disease recurrence. For these reasons, it is important that thoracic surgeons get adequate training in both mediastinoscopy and the needle-based techniques like EBUS TBNA or endo-ultrasound fine needle aspiration, and that the focus of lung cancer diagnosis and treatment be a multidisciplinary approach with a close collaboration of the radiologists, thoracic surgeons, pulmonologists, pathologists, and oncologists to ensure the optimal patient management at all stages of the disease. Thank you. Thank you very much.